Hey girlfriend, this is Jan James. Welcome to the Hope After Breast Cancer podcast, where women who have endured breast cancer learn to have fulfillment over frustration, clarity over confusion, and faith over fear. We tackle the issues that many of our sisters face after a breast cancer diagnosis, from brain fog to fear of recurrence, from menopause to sex after breast cancer. This is the place to learn how to have hope after breast cancer. So strap yourself in. Welcome to the Hope After Breast Cancer podcast. Hi everyone, it's Jan James with Hope After Breast Cancer and Thriver Nation, and I'm delighted to introduce you to one of our latest new experts, contributing experts, Dr. Cheryl O, and she is an OBGYN. And Cheryl, welcome. So glad that you're here.
Hi.
Hi. Hey, can you give the girls a little bit of background about you? And I know that you are just recently done with treatment as well, so you absolutely know what we're all going through.
Yes. My name is Cheryl. I'm an obstetrician gynecologist in Charlotte, North Carolina. I'm originally from Oklahoma, moved to North Carolina initially for medical school back in 2006, and loved North Carolina in the area. So went into medical school not really knowing what I wanted to do, and ultimately fell in love with OBGYN for a multitude of reasons. But primarily because I get to keep my patients for years on end and really form close relationships with them. So I moved to Charlotte in 2014. Once I finished my training, I did my training at the University of Tennessee, Knoxville. And have lived here ever since and really love the community and the city here. So I treat women of all ages. I think my youngest patient is 11 and my oldest patient is 88. And so I definitely see a wide range of female issues. And I do still practice both obstetrics and gynecology.
And do you do surgery? I don't think I asked you that when we were.
I do.
You do as well. Okay.
So I operate, I see patients in the office, and I do delivery. So
oh my gosh,
fairly busy over here, but really I enjoy it, and I really enjoy my patients. And so in February of 2021, I was diagnosed with triple positive breast cancer. I underwent a lumpectomy in March of 2021, and then did chemotherapy from August until the end of July, or not August, from April to the end of July of 2021. I then took a little bit of a break. Had a bilateral mastectomy in October, and then started radiation in December, and I just finished that in January. So since I am HER2 positive, I am one infusion away from finishing my year long of HP, and that will basically put me at the end of active treatment. So I am 36. I've never been married. I don't have kids. So I did do Lupron throughout my chemo in hopes of preserving my fertility, and then stopped up until last month. So now I have resumed Lupron for the next 5 to 10 years. And I'll probably start my AI at the beginning of this upcoming month.
Gotcha. Hey, what has surprised you about coming to the patient side of the house? Have there been things that you've gone, wow, I didn't expect that?
I will say that I don't know that I would necessarily have had, first of all, I think I've been very fortunate. My physicians have been fantastic. I've only had one negative encounter from a patient perspective, and that was actually with an anesthesiologist for one of my procedures. Otherwise, my oncologist, my surgical oncologist, my plastic surgeon have been great. So I feel like I have been very fortunate in that manner, because I've definitely read multiple people's stories as to how they felt like they were treated throughout the process.
Mm-hmm.
But I think definitely now going from the physician side to the patient side, part of it is recognizing the things that you really honor and appreciate as a patient. You know what I'm saying? That basically definitely makes you look at how you treat patients, good and bad, right? Just the things that you do that you also appreciate being done for you. And then maybe some of the ways that maybe you could even be better for your patients, because now not just being a patient, but being a patient who has cancer and really, and just because I was a physician prior to becoming a patient, I really knew very little about breast cancer, even because ultimately, while I send women for mammograms, I do breast exams, I don't actually treat breast cancer.
Right.
So my
Right.
patients who are breast cancer survivors, either I saw them prior to them starting treatment, and by the time I've seen them, they're basically already on the other side, or it's a remote history, so they're remote from it. You know what I'm saying?
Right.
So it's very rare that I see patients in the midst of their treatment to actually know what it was like. And I get it, right? Because as a patient, as I was going through treatment, especially since I required chemosurgery and radiation, you don't really have the bandwidth for much else,
Right.
you know? And so what I wasn't doing was going to other physicians for other smaller things, right? Because at this point, I'm seeing so many people so often for so many other things. It makes everything else pale, and you just don't feel like I have the time to be ripping and running for this or that. You know what I'm saying?
Right. Yeah.
But with breast cancer specifically, I think I was just surprised, by just the longevity of treatment. So, it's not just, I definitely recognized I had a gross misunderstanding of what it is to go through breast cancer and how long you're treated for, how many different types of treatments there are and treatment options. And then the fact that breast cancer, and not to say that other cancers are not potentially similar, but when you start looking at having to be on an AI or Lupron for how long, you continue to potentially suffer, have issues, and just the long-term effects of all of this. So I think that is really where my surprise came in.
Sure. Makes sense. And I think you and I talked when we first got on the phone about the fact that Hope After Breast Cancer was really birthed out of what I found the need to be, in that women, when they were out of active treatment, so they were only seeing their onc, every 6 months or every year,
right,
had lingering different side effects, unseen wounds that they didn't know how to heal, and really couldn't quite figure out who to go to get answers. Or even worse, we're told, well, gosh, we don't think there's answers to that. Suck it up, buttercup, right? And I was like, I don't think that's right. So we've really been blessed with experts like you that have professional background, that are able to really advise us. You don't know us as patients, but generically you can advise us about different things. And the first question that we want to talk about from our group of women is specifically about monitoring. That's a real, your story is really interesting, because when you're saying, you're seeing doctor after doctor, and we've all felt that way, going to see a gynecologist as you're going through breast cancer is like the last thing on your list. And quite frankly, like, I don't want one more poke and prod. I'm not interested. Everyone knows exactly what my breast or lack of breast looks like, and I'm not really interested in having a vaginal. So, it's one of those things. So Bonnie asked, there's two questions, and I think you'll be able to probably take both of these at the same time. Bonnie says, I'm on tamoxifen, and I know that puts me at greater risk for endometrial thickening and cancer. How concerned do I need to be, and what monitoring should be done? And then Jennifer says, what exams are needed to monitor the uterus when taking tamoxifen and in chemopause? Normal pap and pelvic, or is there anything else needed?
So those are both actually excellent questions. I actually remember the very first time I encountered a patient on tamoxifen. It was probably my second year of training. So that was actually a really big learning lesson for me, because ultimately, when a woman is on tamoxifen, it really does thicken the endometrium, but it's not necessary. But a thickened endometrium in a woman who is who's on tamoxifen is not always mean there's something brewing or cancer coming up. And so really the monitoring should be just your regular pap smear and pelvic exam. And if you start bleeding, then you need to be seen, and seen soon. At that point, what you need is an ultrasound followed by an endometrial biopsy and or DNC, just depending on what your discomfort comfort level is. So endometrial biopsy is considered to be equivalent to a D&C in terms of a pathological diagnosis, meaning that if you have an endometrial biopsy and the results are negative, then the likelihood of cancer is exceedingly low. It's not as though if you have an EMB, an endometrial biopsy, and then it's negative, you should go for a D&C. With all that being said, for any woman who's been through an endometrial biopsy, they are very painful in the office. And so depending on potentially how long it's been, if you suffer from vaginal dryness or poor elasticity, as many of us do who are on Lupron, AR, or just postmenopausal in general, you may feel as though you would be more comfortable proceeding with the D&C. So never be afraid of, even if you want to allow your physician to try it in the office, but saying that no, that this is too painful and that you would prefer to do a D&C where you would be put to sleep and thereby would not be as uncomfortable with it. We tend to go towards endometrial biopsies because, I mean, they are easy for us to do. And obviously there's a cost savings both to the physician and to the patient. But I've definitely had patients who either can't tolerate an endometrial biopsy or their cervix has become so constricted, you can't even dilate them enough to get that small pipelle through. And so at that point, we just do a D&C. And with a D&C, oftentimes you can get that scheduled within 1 to 2 weeks. And don't worry that 1 to 2 weeks would ultimately change what's going on. That would be a reasonable amount of time to get that done within.
Gotcha. Wendy was asking in the chat if the thickening of the endometrium is the reason why she gets such heavy periods.
Yes.
Okay.
So bleeding on tamoxifen oftentimes can be very irregular. It can be very, very heavy. So I know for some women, that is what has potentially pushed them to opt for a hysterectomy or something of that nature, both for they just can no longer stand the being on the tamoxifen, and perhaps, they're tired of being on Lupron as well.
Right. Okay, let's move on to, this is such an important question. We're just passing 8,000 women in our Sex After Breast Cancer group. And so everyone is waiting with bated breath for what you're going to say about this. Natalie says, is it safe to use low dosage of estrogen insert for vaginal dryness and painful sex? And then Joanne said, is it safe if you have estrogen positive breast cancer, and does being on letrozole make a difference? She's using Vagifem 10 microgram vaginal tablets. Now, this is, I don't know if this is in your lane or not, because I have a medical oncologist who is absolutely rabid about me not using estrogen products. And the girls know I've gotten kind of, activist in the group about be careful, I went all mama bear on him, and, but then I have learned from our women too that there's a quality of life issue. Like, what is the risk? It's the risk reward kind of equation. So what is your input? And then, like, where should a woman bring her oncologist into the discussion?
So I will say this is a loaded question, a good question, but a very loaded one. So I think before we quite answer the question exactly, there are, from a prescription basis, 3 options for improvement of vaginal atrophy, vaginal dryness. You have your vaginal estrogens, which are available in the vaginal cream, such as estrace and Premarin, or the tablets like the Vagifem. You also have another medication called Intrarosa, which is another vaginal insert, but it is not actually estrogen. Instead, it is a steroid analog. And then you have Ospina, which is actually a tablet that you take by mouth every night before bed, which is another steroid analog. Now, all 3 of them on the warning labels are contraindicated, meaning not to be used in women who have breast cancer. Now, with that being said, when you actually go back and look at the studies, when it comes to vaginal estrogen and even the steroid analogs, the amount of hormone that is able to get into the bloodstream is exceedingly small. And so it really is felt that on that basis, vaginal estrogens whether it be the inserts, whether it be the creams, whether it be the tablets, are more likely safe in women who have breast cancer. Now, physicians, just like any person, are all different. And not only are they different as people, but we're all trained differently. And so my rule of thumb, even prior to my own diagnosis, has always been, while I don't have a problem starting a patient with breast cancer, even someone who's estrogen positive, on a vaginal estrogen, because the likelihood of it being a high enough amount to activate any sort of circulating cancer cell is exceedingly low. With that being said, I always give deference to the patient's oncologist. And so for patients who have...
Yeah, women may have particular circumstances, right? Which is where I appreciate you saying that, because I think that your oncologist knows your specifics best regarding cancer, right? And so I think it's a team sport, right? We've got to get everybody into the pool and everybody into the discussion. So
correct. And so what I've always done is that while I will still go over all of the options, and the Intrarosa and the Osphena are probably safer because they're not an actual estrogen form, but I've always told them that I will communicate with their oncologist. And if their oncologist says that they're okay with it, then I have zero problems with prescribing it. And I think from that point, if your oncologist is okay with it, that's really when it then comes a quality of life. And you as the patient have to decide, how is your quality of life affected? Whether it be your marriage, whether it be because you're trying to date again, whether you're just having pain, whatever the case may be. And you then have to weigh the risk out for yourself, ultimately. But I will say that when you look at the studies, they are safe. Now, obviously, you're going to have some oncologists who truly believe no estrogen of any sort. They're not willing to take the risk at all. And at the end of the day, the way I look at it is very similar to what you said, Jan. If I'm your oncologist and I'm taking care of you, and not only that, but this is their bread and butter, right? This is what they see day in and day out. And so who knows what their own personal experiences may have been with a patient over time that maybe influences how they feel. I mean, and now don't get me wrong, we all have fought to still be here another day. And so at the end of the day, we didn't all fight to be here to be miserable.
Right.
You know, so you really have to look at where your life is, what is your quality of life, and if you can't make it through the day and you have tried every other thing, right, then you have to do what's best for you, right? Because let's be honest, some of us have chosen to not use our AI. Some of us have chosen to do tamoxifen instead of the AI, or no tamoxifen either. You just have to figure out what is really best for you now that we are in this non-active treatment phase.
Right. Now, something that I learned from our first expert, who happens to be also an OBGYN, and she's a women's health educator. It's really funny. I had to switch docs because of my insurance change. And I went to her, and as soon as I kind of understood what her background was, I was like, hi, did you want to be an expert for our Sex After Breast Cancer group, right? Like, boom. And so one of the things that she taught me was that so many women self-diagnose in the days of Google, right? Like, ladies, you're out there going, oh, I keep hearing vaginal atrophy, so I must have vaginal atrophy. Is it true that they should see a gynecologist to actually be diagnosed with what needs to be treated?
I do think they should see a gynecologist, because ultimately what you may find is that, because I know that I'll have patients who come in and like they feel like they're having dryness or pain, and you'll do an exam and everything is really very well lubricated, right? Because you can really see at what is atrophic versus not, and what is the severity of it. And you and your gynecologist may have some tricks up their sleeve that you maybe haven't tried or haven't seen that may really improve things that don't require anything prescription or anything with that's estrogen based. And so,
Right,
I think it is worthwhile to at least get a good exam.
Right. Despite the fact that we don't want to see more doctors. However, ladies, I would tell you it's worth your while to do it because you don't want to treat the wrong issue. Or, like you're saying, oh, I must have vaginal atrophy. Then you treat that according to what our experts are saying, but you didn't really have atrophy. You have muscle issues. And really what you should have done is gone to see a pelvic floor physical therapist.
Correct.
So in our, I just want to say this for the record for the girls, in the guide section, when you go to the guide section of the page and you go to start here, there actually is a discussion about that it's not quite wise to do your self-diagnosis, Dr. Google, and we're all guilty of it, right? We all do that. But I think that seeing a professional, a gynecologist, to really figure out what's happening before you try different treatment plans is better. Is there a Reader's Digest version to say how vaginal estrogen works? Wendy was asking about that.
I don't know that there is. I haven't ever seen one, but
little short thing, yeah, right.
Yeah, so depending on what you're using, so like for instance, Osphena, which is a tablet, actually helps to rebuild the tissue underneath the vaginal mucosa. So it actually not only helps with increased lubrication, but it actually helps make that tissue thicker, so you have less tearing, less lacerations, and you get good lubrication.
Perfect.
It's also nice because since it's a tablet, you just take it by mouth, so it's not as messy as a lot of the creams are, but it does worsen hot flashes. So that is something to think about. So if you are having the horrible hot flashes, that may not be a great option for you.
Right.
Whereas it's something like Intrarosa is a steroid that really works, specifically targets a hormone called DHEAS in the vaginal walls. So that's actually how it works specifically to help increase your lubrication. But it is a vaginal insert. There's not a generic of it yet, so it can be expensive. But for my patients who have used it, both with and without breast cancer, they have loved it. It's actually probably one of my more favorite ones to prescribe to patients, especially because you can tell them that it's not an estrogen, because it's not.
Right. Awesome. So that's good. Can you explain the difference between Thermiva and Mona Lisa?
So I've actually never done a Thermiva. I was actually trying to look that up.
Okay.
I've heard of the Intrarosa, and I have not a partner, but we actually have a physician here in Charlotte. Her name is Elise Kelly Jones, who is actually basically an expert in sexual issues, sexual dysfunctions. So she's actually the one who does the Mona Lisa here in Charlotte. I don't have a lot of patients who have gone the route of the Mona Lisa, but I do think it can be helpful. I don't know how helpful it is for just atrophy.
Right.
But I don't do either one.
That's not your specialty. That's okay. And it's really been interesting in the group over the years as Mona Lisa has kind of been more, people have become more aware of it, that like, this is totally unscientific. This is not, I'm just Jan. It just feels like it's kind of a hit and miss kind of option that I'd say half of the girls have some success with it and half of them have no success with it.
And so that's what I would say for my patients as well. I would say it's one of those where it's not really all that cut and dry. And unfortunately, I think that Mona Lisa was very popular when it first was introduced. Right. And I think that it was thought that it was basically going to kind of like completely change the world of vaginal atrophy and postmenopausal dryness and painful sex. And I don't think that it has lived up to the expectations. And I don't feel as though people are doing it nearly as much as they did when it first came out, because it is also fairly expensive as well.
Right, exactly, right. Yeah, now back to the treating atrophy and dryness. There's a question from Melissa that says, are there things that can prevent atrophy and dryness that isn't hormonal, which you discussed, and doesn't stain our panties and sheets? Do you know if the Aspina and what was the other one?
Intrarosa.
Intrarosa, right. Are those a staining kind of thing? That's a very technical question. Yeah.
So Aspina is not, because it's just an oral tablet. So that was, I think, always one of their biggest selling points. It's just an oral tablet that you take at night. So you don't have to worry about the messiness. Now, Intrarosa is another vaginal insert. So you're going to have the messiness like you do with all the other forms. Now, as far as things are not hormonal, that's where you kind of go back to coconut oil, vitamin E oil. Someone I saw in the group, and I can't remember the name of the medication, but recently posted about a I don't know if you call it an herb, essentially, that you can really buy on Amazon, that they found to really improve their dryness, that they were taking every day.
Was it the buckthorn oil? I think I saw something about that. Buckthorn oil? I don't know.
It might. Let me see if I can find the name of it real quick while I continue. But what I was going to say, as unfortunately, there's not really a good manner for prevention. The problem with atrophy is this really is due to a lack of estrogen. And so the only way to prevent it, right, is to not become menopausal, whether it's from you're menopausal because of taking medication, or you're menopausal because you've naturally just gone through menopause.
Right.
Ultimately, when you're talking about prevention, it's really probably more of in a dry, and unfortunately, and as much as I hate the term, it really is true. Yes, the sea buckthorn oil blend. So I saw someone had kind of swears by it, so that might be an option for people to try. And obviously, all of these things, there's nothing negative about them. Can't promise success for everybody. But going back to what I was saying, the whole, you lose it if you don't use it. And I mean, you hate to say it, but it really is true. The vagina is meant to stretch. It's the whole reason why we can have vaginal deliveries. And so what's hard is that the longer you go without sexual activity, and that's really the reason why dilators work so well, is it is physically stretching the vagina over time and getting it used to being stretched like that again. But when you're going weeks, months, years, and you're not sexually active, the problem is you enter into a vicious cycle, right? So let's say it's been 2 years since you were last sexually active, and you've been on like a Lupron and an AI, which now you are clinically menopausal. Well, your vagina has lost so much estrogen, and that's really the problem when you don't have estrogen. You don't get that natural stretch, not even just the lubrication aspect of it. You don't get that natural stretch. So now that it's been that amount of time, it is painful, right? It hurts. Maybe you have a laceration. Maybe you end up bleeding. Well, if something hurts that much and it's not something that is necessarily vital in that moment, would you be willing to do it again to get back to the point where it is manageable? Do you see what I'm saying? And so what happens is it hurts the first time. It's uncomfortable. So maybe you wait a week, you wait a month, you wait 2 months. Well, you just kind of keep prolonging the cycle. And once again, I totally understand. I totally get it, right? We go through a lot as breast cancer patients. You have been poked, you have been prodded, you have surgery. You don't look the way you remember. You don't feel good. Maybe your weight has gone up from the chemo, from the steroids. And who then wants to be having sex?
Right.
I mean, you want to feel normal. You want to go back to yourself, but then it's very difficult to push yourself to do that, And so it ends up becoming a very vicious cycle. I see this a lot in my patients too. You've had a baby, your body has changed, and who knows what type of laceration you may have had, who knows what your birth story may have been. And it gets very difficult to get back to the way things were. But I will say that, and I would, my guess, my patients who are in very healthy relationships, once you kind of get back into the rhythm of having sex and you find something that works for you, it gets better and better. And because I mean, I've also seen plenty of patients who are able and capable of having great sex, and more so libido is their issue. They just don't really desire it. But honestly, the more that you have sex and you have that stretch, the less pain you will have over time.
Mm-hmm. Very good. Well, and back to that painful sex, we have had some women that have had tremendous success with pelvic floor therapy. So can you explain kind of how that works and what pelvic floor therapists do to help
so
with
they actually do several things. So one thing, like I remember I had this patient who went, and so because I also see a lot of patients who potentially had traumatic events happen as children, whether it be that they had a traumatic pelvic exam in an ER or were a victim of rape or molestation, who then as adults suffer from significant sexual disorders secondary to pain relating to that initial event. And so I will a lot of times, if they are willing, we'll send them to pelvic floor therapist, because number one, I think you're being examined in a way there's no pressure, right?
Mm-hmm.
When you're in a relationship and trying to have sex, there's that pressure to perform and the pressure of trying to save your relationship.
Right.
With the pelvic floor therapist, that's already off the table. So number one, they will oftentimes help you with dilators. So, starting at the very smallest size and starting to help with getting those vaginal walls stretched so that you can be able to accommodate a penis with minimal to no difficulty. They also do a lot of biofeedback. So a lot of them will do like electrodes and really look at, depending on like where your pain is located, to really help you to relax, knowing where the muscle tension is. And so that can be exceedingly helpful. And then just helping teach you how to learn your own pleasure triggers, how to do muscle control for those who maybe suffer from some prolapse, because sometimes people with atrophy will end up having more prolapse, especially in your older patients. And so personally, I find that pelvic floor therapists are really invaluable and really, unfortunately, not used enough.
Right. And so there are directories online, and we have some pelvic floor people that are associated with us as well. So yeah, I highly recommend that too. I had no idea how many muscles were in the pelvic area. It's ridiculous. It's really like they call it like a basket, don't they, Cheryl? That there's a basket of muscles, and it's shocking. So if your muscles are tensing up for various reasons or whatever, then penetration would be really difficult. And so you just need to know about that. So we're really trying to get the word out. Okay, let's move to menopause. So a couple of questions here. Susan says she's in chemopause, and there's lots of books out there about how to go through menopause naturally, but the ER/PR positive ladies are just thrown into menopause at treatment without regard for what it entails. And she said she already takes the maximum dose of Effexor, but still has hot flashes. Any words of wisdom there?
So here's what's really hard. Going into chemopause medications is very similar to when you have your ovaries removed, in that you were this completely normal, completely functioning woman, and then you overnight essentially went into menopause. And so the menopause symptoms tend to be more severe than in a woman who went through menopause naturally, because when you're going through naturally, you're losing those hormones over time, and that time is typically over years, not days. And so and not to say that women who go through menopause naturally don't ever have severe symptoms, some do. But for women who go through either surgically or medically, it just tends to always be severe. There's not really a mild version of that. You basically you've literally thrown your body into the deep end without any sort of life vest. Right. And so in order to deal with, and so ultimately it comes down to, what are your symptoms? Whether it be hot flashes, whether it be night sweats, whether it be mood swings, whether it be the vaginal atrophy. And so what I tell, and unfortunately for hormone positive breast cancer patients, estrogen is not an option, right? So essentially everything else is a secondary option, and none of them are truly tried and true in terms of everybody doesn't benefit. So antidepressants like Effexor can help with hot flashes, but they don't help everybody. Increasing soy will help some people, but not everybody.
Increasing soy. Wait a minute. I was ER positive, and my aunt said no on soy ever. So
because of the phytoestrogen. So
right.
but that is not as clear cut. But especially for my non-cancer patients, because ultimately, for whatever reason, when you look at Japanese culture, they don't go through menopause as severely as we do, and so the thought
interesting.
Wow. That the increase, because they have so much soy in their diet, that is potentially why. And so some people will actually have some benefits, and so especially for your patients or for people who maybe are more plant-based and tend to have more soy in general.
Gotcha. All right. Interesting. Yeah. Yeah. Susan also said she her estrogen levels were reduced by going through chemo, but not enough to take an AI. So she takes tamoxifen. I was a little confused about that because I thought tamoxifen was only prescribed for pre-menopause. Am I wrong?
That's always been my understanding, is that those who are prior to menopause, and I think there's some other factors depending on what your not ER, but your other like HER2 and things of that nature, those patients were put on tamoxifen, and typically it was your postmenopausal patients who did an AI.
Right.
And so I'm not, I guess, without knowing Susan's age,
yeah,
I guess would be that she must have been premenopausal, is what she's trying to say.
Yeah, maybe.
But one thing I would say for her is that people do get periods on tamoxifen. They can be very all over the place, though. So don't necessarily think that you won't have a period on tamoxifen unless you're also on Lupron.
Okay. Okay. So, and she was asking, you saw that question, that is the small amount of estrogen contributing to buildup of the uterine lining, and will that shed, or will she have to have it removed?
No, so your uterine lining is being built up because of the tamoxifen, since tamoxifen can cause endometrial thickening. So in terms of having her uterus removed, that's really going to be up to her in terms of either how is she dealing, like if she's having bleeding, is she having any issue with the bleeding? Is it causing her any issues? And so that would really be the reason to do that.
Is that a baby to deliver? I just need to ask.
Nope, it is not.
Okay. Just checking. Okay. No. Okay, we just have one more question that we know of, and then we can ask gals if they want to pop on and ask you any questions.
Yeah.
Karen said, any tips for deodorants, which that was a great practical question. She's on tamoxifen and she thinks her sweat is smelly. I have noticed too, when I exercise, my body odor seems odd, since cancer. So different. But what's happening there?
So I actually don't know. I've actually never had anyone ask me about that.
Yeah, so I don't know. And I, from that question, the way she phrased it, I was thinking, I think she means that her regular deodorant isn't working. But for me, my deodorant works, but it's just that, like, when I'm sweating, I can just smell. I just have a sense that my smell is not what it used to be. So I don't, your body chemistry changes as you go through all this treatment and everything. So there you go. So, okay, ladies, do you have any questions that you want to put in the chat? Let me see if I can see what's happening here. Hang on. Bunch of questions. Hang on, let's see. As I said, I'm on my phone, so it's I wish it was a little less
so I can
difficult.
See. So it looks like the first one was asking about the Reverie,
right,
which I think is a DHEA product that people have really enjoyed and used and liked. But once again, I think it's hard, right, is expense. First of all, cancer is expensive to go through, but patients really do respond well to it. So another great option for patients who are having vaginal dryness to use the Reverie. And I think the nice thing about the Reverie is I don't think it necessarily has to be used every day. I think it's one of those things that you can use kind of as you need it, or like a couple days a week. Now, as far as the omega-3, once again, I haven't had any patients use it. I just saw it in the group a few days ago. And ultimately, I think it's another one of the things, I think it's worth a try because it's not going to be harmful and there's no hormone or steroid analogs in it at all whatsoever. So to me, like, why not try it? If it doesn't work, it doesn't work. But if it works, then it would be great.
Right. Great. Well, that's awesome. Yay, Cheryl. Okay, I want to honor you by not butchering your last name. Can you give us your entire name?
Cheryl Onwuchuruba.
And I apologize that I just didn't want to butcher it at the beginning.
That's okay.
Because even your Facebook profile says Cheryl O. So, yeah. Which I think is a really funny name for an OBGYN. That's hilarious. There's your pop. Look at your pop. That's awesome. Well, listen, thank you so much for sharing your time. I know you're a busy lady. So we thank you for all that you're doing for us and for women all over Charlotte as well. And so thanks. And we'll see you again, hopefully in a few months, Cheryl. That's awesome. This is Jan James for Hope After Breast Cancer and Thriver Nation. And we'll see you next time. Thanks. Girlfriend, thank you so much for listening to our podcast. I hope you found some nuggets to encourage you and give you hope. Make sure you subscribe to the podcast. You never want to miss an episode. And we'd love to know how we're doing, so please be sure to leave us a review. Until next time, this is Jan James encouraging you to remember there is hope after breast cancer. See you next time.